Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello, and welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and we're talking all about the uterus today. I love answering your questions, and have you ever wondered what some of these uterine tests, uterine findings, what should you know about your uterus if you're trying to get pregnant? Today I am answering your top questions all about the uterus and getting pregnant. Before we dive in, these are voicemail episodes. So if you would like to call and leave your own voicemail, I would love that. The voicemail number is 657-229-3672. Again, that is 657-229-3672. Now, before I dive in talking about the uterus, I do want to let you know a few things that are going on. One is that in addition to the voicemail, you can also ask questions on Instagram on Monday at nataliecrawfordmd. All of those questions can be addressed in the newsletter, on Instagram, on the podcast. So you're going to want to sign up for the newsletter so you don't miss questions there as well. nataliecrawfordmd.com/newsletter. You will get access to the TTC starter guide, and soon we're having a recipe kit that will be released as well, and you're not going to want to miss that. The uterus is obviously a very essential piece of getting pregnant. And one thing I find is it's often one of the things that's dismissed or not talked about or tested. That can be really frustrating if you're a patient because you know this is important, yet the tests are a little bit different. And I've had patients have embryo transfers at other places without even having what we call a uterine cavity evaluation. So when it comes to the uterus, very, very quick review of some facts before we jump into our questions. I want you to remember that the uterus is divided into 3 layers. What we consider to be the serosa, the outside of the uterus. We have the myometrium, which is the muscular portion of the uterus. And you have the endometrium, which is what grows and sheds when you have your period. The uterus is actually formed in 2 different pieces. We call these buds, 2 Mullerian buds. When you're a baby inside your mother's womb, these buds elongate, fuse together, and then the midline portion reabsorbs. This leaves us with the top 1/3 of the vagina, the cervix, the triangular shaped uterus that we think about, and the 2 fallopian tubes. The ovaries have a different embryologic origin. The lower 2/3 of the vagina have a different embryological origin. And you can have failure around any part of this system. You can have no uterus formed, that's called Mullerian agenesis. You can have a single uterine horn called a unicornuate. You can have 2 horns, which never fuse together, called a didelphys. You can have a heart-shaped uterus, which is partial fusion, called a bicornuate. And the most common abnormality is going to be failure of complete reabsorption of the fibrous middle septum, leaving what we know as a septum. These are often treatable, but it really does depend on so many circumstances. And then a quick reminder that it's not just the uterus which controls if you have a monthly cycle or not. It is a play between the brain, the ovaries, and the uterus. The brain sends out signals to get the ovary to grow an egg. As that egg is growing and maturing, it's going to make estrogen. Estrogen grows the lining. After the egg ovulates, progesterone is going to be made from the corpus luteum, which is the same follicle the egg came from. That corpus luteum is only going to live about 12 to 14 days until it dies, unless you get pregnant. But presuming you don't get pregnant, the corpus luteum will die, progesterone will drop, and you'll get a period. Now, in some cases, when you're not ovulating or not regularly ovulating, you may have no estrogen, you may have a little bit of estrogen, and on some types of contraception, you might have extensive progestin, a type of progesterone exposure, and all of these things can interfere with the lining. So with that very, very brief overview, we're going to dive on into some of your top questions about the uterus.
Hi, Dr. Crawford. I am calling with a question about scarring in the uterus. The long story short is that I will say your podcast and content really helped me advocate for myself when I was going through my fertility issues, which was 2 miscarriages, but ultimately resulted in my daughter, who is now 18 months old. And we are done now having kids, but I continue to listen to your podcast and follow your content. I just find it so invaluable and continue to really love it. So the question that I have for you is, after one of my miscarriages, I had a D&C, and it resulted in some scarring in my uterus. And we got that taken care of via an operative hysteroscopy. I also had a uterine septum taken out at the time. But after all was said and done, had my baby girl. I've noticed recently, and baby's 18 months, so it's been some time now, that my periods have been a little bit lighter again, which was kind of that telltale sign about the scarring in the first place. And I was curious if there are any implications to that. Spent so much time and so many years just kind of trying to make everything really perfect in there. And I'm just kind of wondering if that's an issue at this point, now that fertility is not really a goal. So I'd love your thoughts. Thank you for everything you do.
All right, this is really a great question, talking about at what point do we need to worry about some of this uterine factor when we're done with our family. And congratulations. I know it sounds like it was a long road, multiple surgeries, procedures to get there. I know how tough that can be, so I'm glad you're in the position to be asking about after fertility. The very simple answer is that if the endometrial layer is damaged, scar tissue can form, and really the endometrium has 2 layers. What we like to think about, the basal layer, the bottom portion of the endometrium, is what has the stem cells that can regenerate the endometrium. So if during a D&C perhaps they scraped off the top layer of endometrium but got into that bottom layer, that leaves an area where you can get scarring. In short, scar tissue inside the uterus when you no longer want to get pregnant is not a problem. Not going to cause an issue, not a problem. The more complicated answer is that it does actually depend if you have no bleeding or some bleeding, and where it can be problematic is if there's some scarring, but also some area of healthy endometrium that is hormonally responsive. In this circumstance, you might be trying to shed, but this endometrial tissue can't come out the cervix because of the scar tissue, and you could get pockets of endometrial tissue inside the uterus. This is affectionately known as a hematometra. It's really blood-filled uterus. And eventually it can cause uterine distension and uterine pain, and so we hate to see this for patients. 2 thoughts. Number 1, an ultrasound can help identify if this is going on. So you could tell your doctor, if you get an ultrasound, there's not a huge pocket of blood or weird accumulation of tissue in the uterus, you're going to feel better about it. A saline sonogram is more accurately going to diagnose if there's scar tissue causing the problem. If there is blood backed up, endometrial tissue backed up behind scar tissue, I would recommend surgical removal because that blood can get infected. That's a whole different issue we don't want you to have to deal with. So in addition to pain, we don't want to have an infection. So I would get the scar tissue taken out so that you can evacuate the old blood, and then might consider some type of suppression so that you don't ovulate and have this problem happen again. The scar tissue might come back. So you'll have to decide if you're going to have extensive scar tissue resection, healing process, or if a better option is to evacuate or drain that blood in the uterus. And then think about placement of a progesterone IUD or continuous oral contraceptive pills with estrogen and progestin. There's no right or wrong answer, but would definitely want to have a game plan so that this doesn't come back again. Most likely, based on your history, that's not the case, and you might have a little bit of scar tissue that is not impactful, and I would not go through a surgery personally to get that removed. Either answer is right, but if you don't want future fertility, the presence of scar tissue alone is not causing any problems.
Hi, Dr. Natalie. Just want to say, first off, I have really enjoyed watching your videos, your podcasts. They've been so helpful to me as I've gone through this journey. So a little bit about me. I have endometriosis, history of fibroids. I'm in the middle of my IVF cycle right now. I started with estrogen priming, and then I'm doing Follistin, Menopur, and then also recently started Ganirelix. However, on my last set of labs and ultrasounds, came back that they detected some fluid in my uterus. Doctor is recommending after we complete the retrieval to do an SIS, to do some investigating. Just wanting to know, what are your thoughts about finding fluid in your uterus after beginning your IVF cycle? They think it possibly could be polyps. So thank you so much, and hope to have an answer.
I think anybody who's going through IVF really hates the words fluid inside the uterus. It can lead to a ton of questions, it can be really vague, and often your doctor doesn't have a lot of answers. Because we truly don't. If we had the answers, I promise, we would give them. What your team is doing is absolutely correct. We have to remember that an IVF cycle is not a natural environment. Your body is growing multiple eggs. These eggs are all making estrogen. Your estrogen is getting to what we call supraphysiologic levels, meaning much higher than it would ever be in nature. And in these circumstances, everybody's uterus is going to have a different response. And some people will have fluid inside the uterus from too much estrogen. Some people have fluid in the uterus from too little estrogen. Sometimes progesterone will, quote unquote, cure this or fix the fluid. However, we can also see fluid in the lining from anything disrupting the normal architecture or growth of the endometrium. So things like polyps, blood clots, scar tissue. What I really like about the plan that you've been given is that your care team is saying, hey, let's look at the uterus more before we do an embryo transfer, and they're recommending a saline infused sonogram or an SIS. Personally, this is a uterine cavity evaluation. I'm a big believer they should be done in everybody, this or hysteroscopy, before an embryo goes in your body. And I like about 6 months. I feel like an SIS is good for about 6 months. But let's say you had one a while ago, did a transfer, it didn't work, you took a big break, traveled the world. Now you come back 8 months later. I'm going to want to redo that and just make sure nothing has changed, because things can change with time. So a saline infused sonogram, those are typically done. You'll have your retrieval. Can't do it at the time of the retrieval because the lining is so thick, you can miss things. I always say it's like having a tree stump in the yard, and if the grass is overgrown really tall, I may not see it. But if I go look for that tree stump and the yard has been freshly mowed, I'm going to clearly see where it is. So that's a situation where it can be a lot easier for me. So they're either going to want to do it after you've had your next period, so egg retrieval, have a bleed, then go and look, or they're going to want to put you on birth control pills after your period and do it on the pill. The advantage of the birth control pill is that it's keeping the grass freshly mowed, and they can more quickly turn around, diagnose something, and go to surgery. If you are not on the birth control pill, you might have one cycle where they diagnose it, and you might have to wait a whole nother month before they can go to surgery to take it out. And that can just be frustrating to feel like there's a delay of time. But absolutely, if the lining's not looking good, I'm glad we're not talking about a fresh transfer. I'm glad they're not talking about, let's just do a cycle and see how it looks. So moving on to further investigation is absolutely warranted. Embryos are precious commodities. You deserve the opportunity to get your uterus in the absolute best condition possible.
Hello, my name is Katerina. I'm from Philadelphia, Pennsylvania. I recently, a month ago, had a hysteroscopy done. I'm doing pre-testing in my fertility center. After the hysteroscopy was done, I completed the course of estrogen and progesterone, which I completed almost a month ago. I would say like 3 weeks ago. According to my calendar, I had to have a period, like right now, but it's 1 day late, and I did pregnancy test and it's negative. However, I do have symptoms like my breast hurt and I have nausea a little bit. I'm like a little dizzy. That's what I normally get, but there's no blood. I wanted to ask a question: how long for the body takes to kind of like recover and go back to its normal period after a hysteroscopy is done? because now I'm waiting to clean my tubes, and I have to get a period for that, and it's not starting, and it's a little bit frustrating. So I wanted to know your opinion. Thank you. Thank you for your podcast, for all the information. Thank you.
All right. Whenever you are waiting on a period, doesn't that just seem like the worst thing for somebody who's going through infertility? All these months you don't want your period to come. And now when you want it to come so you can get on with the next stage of testing or treatment, it's not here. It can be so frustrating. So I know that. The truth is, anytime we give you hormones, we are interfering with your natural cycle. So whatever your period cycle should have been is not necessarily what it is going to be now. Estrogen and progesterone can suppress your ovulatory drive. So when you're on those hormones, it sounds like you stopped them 3 weeks ago, you are not ovulating. When you stopped them, you would then trigger, hopefully to have an immediate bleed afterward, but maybe not because you've been on the progesterone. But that drop in estrogen would tell the brain, hey, we're not pregnant, and start to have FSH send out from the brain to grow a new follicle. I always say it's not uncommon to have your period be a little bit longer when you're coming off of hysteroscopy and hormonal treatment afterward. Typically, I wouldn't say more than 1 to 2 weeks late for sure. In this circumstance, it sounds like maybe you only stopped the hormones 3 weeks ago, so we're not even at the point where we would anticipate you would have a missed period yet. You might be mid-luteal at the soonest if you started growing that follicle immediately upon stopping the medication. So this means that you very well may have symptoms due to high progesterone. Makes me highly suspicious that you did in fact ovulate. And if you're not getting a period in 1 to 2 weeks, would take a pregnancy test again. And at that point, if it's negative and it's now 5 to 6 weeks from when you stopped those hormones, I would absolutely call your doctor and they will have you come in for an ultrasound and blood work. Or if they don't, ask them, say, hey, it's been 5 or 6 weeks since I stopped the estrogen and progesterone. You told me to call you with my next day number 1. It still hasn't come. Can I come in for an ultrasound so we can see what is going on? So hopefully they just suggest that. But if they try to push you into waiting longer, just ask. Just say, hey, this is really unusual for me. I even had some post-ovulation symptoms. Can I please come in so we can do an ultrasound? And at the ultrasound, we can see, what does the lining look like? Do you have a dominant follicle? Is it a corpus luteum or does it look pre-ovulatory? I often compare this with estrogen and progesterone levels so I can confirm if you did in fact ovulate. And that just gives me all the information that I need. All right, these questions are really great, and I hope you are learning a lot or maybe getting some of your own questions answered. A quick reminder, if you would like to call and leave your voicemail question, you can call 657-229-3672.
Hi there. I have unexplained infertility. Been trying for a year and a half with 1 miscarriage, and I believe a chemical pregnancy as well. I am 38, and unexplained infertility, everything seems normal. I went in for IUI due to our circumstances with my husband's work. He's going to be gone for 7 weeks, so rather than going straight to IVF and doing it on my own, we're giving an IUI a shot while he's, going to be gone, and that's the reason why we're not going straight to IUI, even though I'm, listen to your podcast, and statistically it would probably make more sense to do that. We're just going to go ahead and try this first. My question is, during IUI, I had a really hard time with the dye test, and they actually stopped the procedure because it was so painful and my lips started turning blue, so they decided to go ahead and stop the test. So they were able to see enough where the doctor doesn't feel that my tubes are clogged or there's any issue there, so IUI was okay for us to proceed. But during the IUI, the doctor that did the procedure, the insemination, stated that she believes that part of the reason why I was in so much pain with the other procedure was because I have a extremely tight cervix. And I was just curious if that could be not, an explanation for unexplained infertility, but could it be a factor in your statistical chances on getting pregnant if you have a tight cervix. Because to me, it makes sense that if it's too tight, stuff can't get up in where it needs to go. So I'm just curious regarding that. Thank you.
Oh, this is one of those questions that is very fascinating, and also you're going to get probably one of the answers I say the most. It depends. I think it's really important to understand the difference in cervical stenosis versus a retroverted or an anteverted uterus, which both of these cases can cause difficulty getting a catheter through the cervix into the uterus, but the impact of these and the treatment is going to be different. So number one, if we just semantics, your cervix has an external and an internal os. These are the openings of the middle portion of the cervix. Of course, the cervix is the bottom portion of the uterus, and the cervix dilates to 10 centimeters when you have a baby. And it should stay not completely closed, but have a very small opening outside of conception. Your uterus above this can be mid-plane, if we think about it very neutral on the same level of the cervix. So if you take your arm and you think about your forearm as the cervix, this is not to scale, but for the sake of the discussion, and your hand is your uterus. If your hand and your arm are both straight out, this is a mid-plane. You can see how the pathway is a straight shot. That is one of the most common cervical uterine orientations. The next most common is what we call anteverted. We're referring to the uterus, and the top of the uterus, think about where your fingers are, is actually pointed upward towards your abdominal cavity. This makes the internal os on an elevated plane from the external os. Most of this time, this is not difficult. It might take a slight angling of the catheter. Might be a circumstance where we have to take the catheter out or adjust it or get a different catheter, but typically not a huge deal. Now, you can have a severely anteverted. Imagine pulling your hand all the way up so that you're saying stop, your palm forward, and you can imagine that's a really hard angle to make. This is seen sometimes in the presence of you've had prior C-sections where the top of that uterus and that bladder portion even are really pulled upward, making it a tough angle. Retroverted, if we take our fingers and now point them down to the ground, you can see what retroverted looks like. Retroverted, more common or concerning for potential endometriosis. Endometriosis is that inflammatory autoimmune-like disorder, and you get patches of endometrial-like tissue which cause inflammation and scarring. But because one of the places endo loves to grow is behind the uterus, the top of the uterus can often get stuck backwards. Both of these cases can make it hard to pass a catheter through the cervix into the uterus. It's not necessarily the cervix. The cervix isn't having cervical stenosis. It's actually the angle of the uterus. And there's not always something you can easily do in these circumstances. But if we think about it, sperm you see under a microscope. These catheters you see with your eyeballs. So even with these funky angles, the entire ejaculate's not going through there. The sperm should be able to swim through that cervix without much of a problem, even if it's at a funky angle. Now again, if it's retroverted and that's part of the problem and you have endometriosis, that's a different issue. And that's explaining some of our unexplained. Now, cervical stenosis is itself a real thing, varying levels of diagnosis. So this is tough, meaning all the way stenotic is a scarred cervix. Now, if you've had any prior procedures on the cervix, like a LEEP or a cone, then this can be more common. That's where we've cut a portion of your cervix off due to precancerous cells. Or if you've had multiple procedures on the cervix before, multiple potential deliveries or instrumentations like surgeries, sometimes you can have scarring inside the cervix. This scarring can almost act like a spider web and can make it harder for the sperm to go through. Not impossible, but harder. These are cases where definitely going under anesthesia, dilating the cervix, putting a camera in the uterus, looking around can help people get pregnant naturally or with further intervention. There have been a few studies that are both really small, not excellent studies. They're heterogeneous, meaning the definition of cervical stenosis is a little bit vague. But patients who had cervical stenosis underwent hysteroscopy with cervical dilation, some of this fully asleep in an OR, some of this under anesthesia in the clinic, but essentially watching, kind of pushing through and breaking that scar tissue, and then had higher conception rates. So there was one study published in 2020. There were 1,000 women who underwent saline sono, a little over 100 of them, so about 10% were diagnosed with cervical stenosis. And of those women with cervical stenosis, about 80 of them had dilation, the others refused. The group that then had dilation had 70% of those conceived compared to a little under 20% in the group that did not have dilation. And the patients who did have dilation got pregnant faster. This was a study that did ultrasound-guided cervical dilation, so not a full surgery. They just did it in office under an ultrasound. So there's different ways to get there, but I think the take-home message here is that the cervix is the problem or the angle of the uterus. I often find it's actually an abnormally angled uterus, and more often than not, it's a retroverted uterus, which then I'm having red flags go off for endometriosis. If you're concerned, definitely ask your doctor about it. Would a hysteroscopy be beneficial if it was really hard to get through with the catheter? Maybe they could dilate your cervix, or was your uterus retroverted? And could that be concerning for endo? And should you accelerate treatment if that is the case? So no right or wrong, notably a lot of gray here, but a really great question.
Hi, Dr. Crawford. I've been following for a long time and just want to say I really appreciate all of the education that you put out there that allows us to advocate for our bodies and our fertility journeys. It's been so helpful. My question is, my husband and I have been on the journey of infertility for about 2.5 years now. It all started with an accidental pregnancy that happened to be a molar pregnancy, which led to, the 6 months of not being able to try naturally, and then we went into a full year of trying naturally, and that led us down the route of IVF. Throughout that whole process, when they diagnosed the molar pregnancy, they also saw that I had endometriosis. I'm 34 and I've never really had bad symptoms of it, but we do know for certain that it's there. And after we've now had 2 failed transfers and we have 2 embryos left, and I'm just wondering if there is a time to turn to surrogacy as the best option, because it's quote unquote unexplained infertility at this point. I have a feeling I'll never get a clear answer of no, you will not be able to carry a pregnancy in your body, but I want to give these 2 embryos that we have left the best chance. And in my eyes, my body has had now 2 IVF cycles, multiple cycles trying naturally. And so I'm just wondering kind of what the best option is. I know that's a very long-winded question, but whether you get to answer it or not, just want to say thank you so much. I really appreciate everything that you do for the infertility community.
Huge, ginormous hug. A molar pregnancy, if those of you don't know, this is essentially, let's simplify it, abnormal placental growth. It has a risk to turn into cancer, so patients have to abstain from getting pregnant and check HCG for a while, and then a year of trying, and then IVF cycles. I completely understand why you feel the way you do. And let's separate out 2 of the same parts of the question you're asking. Medically, when do you need to move on to a carrier? And can you move on to a carrier? Before I do this, no harm in this terminology. I've seen some people online get really upset about this. The difference in a surrogate and a gestational carrier. A gestational carrier is the medical name for somebody who carries something that is not genetically theirs. So egg and sperm, but it's carried by somebody else. So presumably in this case, you're talking about your embryos that you have and somebody else carrying it. That would be a gestational carrier. I understand that we all call this a surrogate. That's not wrong, but surrogacy traditionally meant your partner's sperm goes into somebody else who's the surrogate. The surrogate is using their egg and carrying the baby and then giving it over to you. And that's considered traditional surrogacy and illegal or not permitted in many places and definitely not recommended, as you can imagine, for many different reasons. All right, logistics aside, a carrier. If you feel like that's the only option, you have to move forward. It's never wrong. That being said, it's a tough journey. You're giving something up. Hugely expensive, hugely expensive. It makes 2 cycles of IVF look like a walk in the park. And so it's not something that is easily done. And for that reason, we always want to look at, is this really what we have to do to get to the next step? I also heard you say at the time of your molar pregnancy something about endometriosis. If you've got endometriosis, it sounds like you don't have unexplained infertility. You have endometriosis. Endometriosis can be associated with recurrent implantation failure, especially in cycles that are not using Lupron suppression with your embryo transfer. And there are some really specific protocols for recurrent implantation failure for patients who potentially have endometriosis. And this is a longer Lupron suppression, typically a couple months. Sometimes with other medications, everybody does it a little bit different. And then there is, have you had a hysteroscopy? Were these embryos genetically tested? If we look at the science, which you guys know I love that, we don't diagnose recurrent implantation failure until you've had 3 euploid, so genetically normal embryos that have failed to implant. So you don't even meet that definition yet. That doesn't mean that emotionally it's not really dragging on you. And we all know emotional dropout, that's the top cause. It's just, I can't keep going. So it's very fair if you say, hey, I don't know that I can keep transferring into my uterus. That has not served me well. I really want to consider a carrier. Be prepared for that to cost $70,000, take months and months to jump through the hoops. Just be prepared. If you're asking, is that the next best option? Well, it really does depend. Have your embryos been genetically tested? Have you done Lupron cycles? Have you talked to somebody about protocols for your endometriosis? Have you done a hysteroscopy to look inside the uterus and make sure there's no scar tissue from that mole? So there's a few different things that I just threw out there that maybe they've all been done, but maybe they haven't. If in doubt, it's never the wrong decision to get a second opinion. Send all your records over, hear what another doctor would say, because they may see something in your record that I don't have, obviously, or ask your own doctor, is this the time for me to move on to surrogacy? So everybody's case is a little bit different, but from the details you've given me, I would not say that you need to start planning for a carrier. When do I say that? Very complex, going to depend on multiple situations. How many embryos do you have? How old are you and can you get more embryos? How many cycles have we been through? Have you ever given birth in the past? Do you have a uterine factor like scar tissue, prior uterine perforation, a traumatic C-section, or do we not know why things are not implanting? Typically, 3 euploid embryos not implanting is recurrent implantation failure. I start bringing a carrier into the discussion once we've passed that 4th failed transfer. Doesn't mean you have to do it. That's typically when we're starting to say, would we ever consider this? How many embryos do we have left? And what makes sense for us? There is no one right way to grow your family. So I really love that you're open and considering all options. More than anything, I'm sending you a big hug because I know you've been through a lot. Okay, guys, I hope you learned something about your uterus and gave you something to think about. If you have questions, please feel free to call 657-229-3672 and ask your fertility questions. You can also ask on Instagram on Monday at nataliecrawfordmd. And don't forget to sign up for the newsletter at nataliecrawfordmd.com/newsletter. Remember, there is short form video content on YouTube. If you like shorter, more bite-sized pieces of content, just search my name, Natalie Crawford MD. Thank you, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.